Hi, everyone. Good to see everyone here. Haven't done these in a while, but glad to see everyone here. See a lot of familiar faces. Hope everyone's doing well and enjoying the fall. A little bit cooler now. Oh, wait a minute. Let people kind of come in here. Right. So yes, thank you, Jen. Jen is our director of marketing, and she's also a clinical nutritionist. But she and I put together this webinar on navigating COVID-19. And as she put in the chat, this webinar will be recorded and we will share the slides. We'll put it on YouTube and Facebook and things like that. If you're listening, afterwards and have a question, just contact us. Otherwise, if you're here listening live, just type something in the chat and select everyone in the blue bar for your message to be seen by everyone so that everyone can see that question. And it might stimulate other questions from other people as well. I know there's a lot of potential, discussion. We really want to make this more of a discussion since this is live here. So again, thank you everyone for coming today for this webinar, Navigating COVID-19. This is September 27th, 2022. We're in the third year now of this COVID-19 era, I would say. And just so glad that everyone's here. Hope you're doing well again. We're going to discuss today some of these topics, again, just to make this more of a discussion here, but here's kind of an outline. We are going to be talking about the new updated bivalent COVID booster. So we'll be talking about that in some detail. We'll also be talking about updates on various therapies for COVID-19, like Paxlovid and monoclonal antibodies. We'll kind of talk about the upcoming couple months where, what's kind of next for both COVID and for flu season, influenza virus. And then we'll also kind of update some things on, our thoughts right now on long COVID, things like risk with the current variant, things like updates on protocols. Knowing that long COVID is not something that we have all the answers for yet. I think everyone's just researching this, trying things out, trying to figure out what the root causes are. So just knowing that. And then just where we go from here in terms of the COVID pandemic, and, are we getting to a situation where it's becoming an endemic situation, or, how do we approach this from here and moving forward as individuals and as community? And then the other thing is that we're going to have a special announcement at the end. So I hope you can all stay for the end of this. But first, I want to do a little bit of a 1-minute meditation. So what I'd like to do is just have you kind of drop in to your heart here and put your hand on your heart, if you would, and just have a moment of reflection for your own health, for your loved ones, for the people that you care about, for your family, for your friends, for people that you don't know, even maybe people that are around the world that are going through tough times, and just sending a message of wellness to all those people, to yourself, to your friends, your family, and to your community, and to those that you don't know as well. Just breathing in through your heart and out through your heart. 2 more breaths like that. Breathing in through your heart. Out through your heart. And one more time. Just feeling the connection as we breathe it together as a community here, wishing each other well, and learning and growing together. So thank you so much for that. Let's talk about where we are right now as of, I guess I prepared this a couple of days ago, September 24th. So we're at about a 1,500 deaths a day from COVID-19 per the records. In the US, we're still above 400 deaths a day of this on the 7-day average. And in Maryland, we're about seven people dying either of COVID or with COVID. And then we have 13 in Virginia per day and 0 in DC. It's been 0 for a while in DC. In Montgomery County, which is where our clinic is, we're averaging about 1 death per day with COVID. Now, community transmission rates, so the CDC changed the definition of what community transmission rates is. So instead of it being a percentage of positive testing, it's now more along the lines of hospitalizations and things like that. So overall, across the board, using that metrics, the community transmission rates in most places in the country, including everywhere in the DMV area, is considered low. Now, President Biden said on the news recently, quote unquote, the pandemic is over. How many people heard that statement? Did anyone read about that? I'm just curious, your thoughts about that statement. We know that COVID numbers are down, and we know there's definitely people still getting COVID, however. Sorry. Oh, Jen, can we go back? I'm a little rusty on these webinars since we haven't done them in a while. So,
yeah, you should be able to just click back using the arrow.
Yeah, that's what I think, but I can't do that either.
Yeah, if it's stuck, just reshare it.
I will reshare. Okay, so how do I? Okay. Sorry about that. Go back here. So President Biden said that the pandemic is over, but I think he clarified that a bit by saying that, you know, sort of practically speaking, there's more things available right now. There's vaccines, there's therapeutics. There is, from a public health perspective, we know that there's imbalances in access to vaccines and therapeutics, which kind of mirror the entire healthcare system. There's certain underserved populations that don't have the access that maybe the entire system does. So that's something to think about as well. There is also a thought of, you know, are we transitioning? A lot of public health officials are now saying that, you know, are we transitioning from a pandemic situation with COVID to an endemic situation when it's kind of there? We're learning to live with it. There's some degree of risk, but, you know, how do we balance that, you know, risk versus the benefit of opening up society? So I'm just curious, before we get into the webinar a bit more, what are your thoughts here on the webinar today of everyone? I'm curious your thoughts on the current state of COVID. How do you feel about it? I'd just love to hear from people. Now, I see Megan and Ruby have their hands up. I don't know if feel free to chat if you want to talk about that. Or anyone. Anyone have any thoughts about this, about how you feel about COVID right now? Just, you can put in the chat box if you want, or later, that's fine. Okay, so we are going to go with a few things in terms of where we are right now in terms of estimates of total immunities. So the way that we've been measuring traditionally in terms of how the immune system has some sort of priming against a future COVID infection or SARS-CoV-2 infection is antibodies, which are secreted by the B cells in the immune system. So the presence of antibodies against this COVID-19 virus or SARS-CoV-2 suggests that a person has previously been infected with COVID-19 or vaccinated. This is also called a spike protein antibody. So this is how we traditionally measure immunity against different things like viruses, you know, mumps virus, measles virus, things like that, and also COVID virus. In the United Kingdom, they've actually done studies on this, data collected from study worker home visits, and they have found that over 95% of people in the UK that they studied have significant antibodies against COVID-19. That means either they've been infected with COVID-19 or vaccinated, or both. So, you know, the overwhelming majority have some sort of immunity there. Now, I tried to find some research on the US, and I think there is some indirect research. We can say that the CDC updates are from February 2022. And at that point, 60% of adults and 75% of children had been infected with COVID-19. The numbers are likely higher now because we had a spike of Omicron in the midsummer here in the US. In addition to that, in the US, there's about 68% of people overall across the whole country, with a range between 50% and 80%, depending on the state, where people are considered fully vaccinated. So at least traditionally that has meant at least 2 doses, although that definition may change over time by the CDC. But at least based on this, in the DC area, we're I think on the higher end of that, in the 75 to 80% range that are fully vaccinated. So extrapolating from that, I would say that certainly similar to the UK, a significant number of people have either had an infection or vaccination or both. It's probably above 90% as well. I did want to mention another test that is available through, I know it's available through outside LabCorp centers, is you can do a test, although it's not covered by insurance, that tests for the T cell response. T cells are another type of immune cell which remains after the antibodies wane. So sometimes you'll see the spike protein levels wane and wear off, but T cells do play an important response in reducing the likelihood of severe disease. And many experts believe, and also I believe, that T cells actually can be kind of like a backline immune system that does prevent against a lot of severe disease once someone has gotten either vaccination or infection. So you can actually test for a T cell response, which is a blood test. There's something called T-Detect COVID test. I think it's tdetect.com or something is the website. And again, T cells that are specific to COVID do increase after both infection or vaccination. So I think this is a nice test if you're interested in that. And if you want to look at that, that is something you can look at besides the spike antibodies as well. That's how we can estimate total immunity. But on average, most people have some degree of immunity towards COVID-19, either from infection or vaccination or both. Okay, chat is now working, is what Jen is saying. So let's talk about the official CDC vaccine recommendations. We'll get into the booster in a second. So here are the official vaccine recommendations link, which is, you can see there on the CDC, but I kind of wanted to summarize that for you. So basically there are 4 vaccines available right now. One is called the J&J adenovirus vector vaccine. Due to the risk of blood clots, that is not recommended for most populations anymore. So I'm going to kind of put that on the side. We also have the original Moderna or Pfizer vaccines. These are the mRNA vaccines that were formulated against the original strain of the virus before it started to mutate into alpha, beta, delta, and Omicron. And so that was from like 2 years ago. And then we have the Moderna or Pfizer mRNA bivalent updated vaccines, meaning there is part original and part of the updated BA.4/5 Omicron variant in those, which we'll talk about in more detail. A fourth one is actually a Novavax protein subunit vaccine. This is a vaccine that uses the traditional what's called adjuvant technology. So a spike protein is bound to an adjuvant, a carrier, basically. Novavax is actually a company that's based in Gaithersburg, right here locally in Gaithersburg, Maryland. And they have also gotten FDA authorization for emergency use. So that's another current vaccine. None of the currently FDA authorized vaccines are live virus vaccines. There are some in the works through different research organizations, through intranasal vaccines and pan-coronavirus vaccines that can get all variants, but these are not available yet. So this is what we have right now. So let's talk about the bivalent booster. Again, bivalent means there's 2 valences. So you have 50% of that booster is against the original strain, and 50% is mRNA of the BA.4/5 lineage of Omicron. So it's kind of a half and half vaccine, I would say. So the FDA did approve this for emergency use authorization on August 31st of this year for both Pfizer and Moderna updated vaccines. Let's talk about how the FDA based their decision. So basically what they said, and this is all on their website, but they based it off of safety and efficacy data for each of the monovalent mRNA, meaning the original COVID vaccines, meaning that they're safe, they're effective, they've been given to millions of people. Now, for the newer research, which is what these links show here, they did test, and this was published in the New England Journal of Medicine, a bivalent COVID-19 vaccine, although that was one with the original vaccine and then BA1, which is Omicron 1. That was tested in humans. I think each control versus study group was about 300, 400 people in either group. They were testing, the primary endpoints were, is the vaccine safe, meaning the bivalent vaccine safe, and is it immunogenic, meaning is it going to increase the level of neutralizing antibodies, which they found that it did. A little complicated here, but there's an analysis that wasn't really focused on, and I would say that this is where it gets a little bit gray, is that they did also do a subgroup analysis that was not considered like part of the main findings of the study. But I should point out that what they did do is they did check to see if the BA1 updated COVID, shot, did that protect against infection, more than the original strain, and it did not in that BA1. But there was no real answer to that question of, is it going to prevent severe infection? But at least, about the same number of people got infected with the BA1 updated vaccine versus the original vaccine. But we can talk about that more a little bit later. And the BA.4/5 bivalent vaccine, that has not been completely studied in humans yet. These studies are ongoing, and we'll talk about that in the next slide. This was a non-clinical data study done in mice that obtained a bivalent COVID vaccine with the original strain in BA.4/5. And there was an increase in the neutralizing antibodies in the mice in that situation. And that was published in the journal Nature pretty recently as well. Okay, so we'll get back to those studies in just a minute and kind of what we're thinking overall. So there is also the newer approved vaccine, the Novavax vaccine. Again, that is a protein subunit vaccine with an adjuvant. Those studies were done initially on the alpha variant, which is one of the first variants after the original, and that was considered 90% effective against moderate to severe COVID-19. There have not been clinical studies done on Novavax versus BA.4/5. There was a basic science study that I found that showed that 3 Novavax doses, meaning like 2 doses, which is a full dose plus a booster essentially. In that study, that was just a basic science study, so it's like cell cultures and stuff, did increase neutralization titers against BA.4/5. So that is promising. But again, that's just a basic science study. We don't know how that would translate into clinical outcomes. And this sequence of 3 Novavax vaccines is not approved by the FDA, just so you know that. So that's the research on Novavax right now. So let's talk about official CDC recs first. So at this point, the COVID vaccination is recommended for everyone ages 6 months and older for prevention of COVID-19. That is the statement there. We'll talk about what that means in practice in one of the next slides. So we see here, and this is not official medical advice, but I would just say in general, if you're listening to this and wondering about your kids that are ages less than 12, currently the bivalent updated booster is not available for this age group. I think it's coming soon in the next month or two, but please see the CDC website. Please talk to your pediatricians, for your kids. For ages 12 through 17, there is a bivalent dose available, which you can kind of see there. You do a 2-dose primary series with either Moderna, Pfizer, or Novavax. And then regardless of if you got an extra booster, like an original booster, you would still be due in theory for a age-appropriate bivalent, meaning updated booster dose after 2 months from the last dose of whatever vaccine you got. For ages 18 and up, then it's similar. Basically, again, you have Moderna, Pfizer, or Novavax available, a 2-dose primary series, and then you have 1 age-appropriate bivalent mRNA booster dose, again, after 2 months after the last primary dose, or if you got a booster dose from the original, you wait 2 months, and then you can get another booster. That's what they're saying there. Now, for people that are moderately to severely immunocompromised, which if you have a question about that, please put in the chat. The Novavax recommendations are the same. The Moderna and Pfizer recs are a 3-dose primary series and then one bivalent booster dose, essentially. So on the summary points of this from the recommendations, so vaccines do not really, we've seen in the Omicron, which is much more transmissible, of course, vaccines haven't been shown to prevent exposure to Omicron. And so really a lot of the public health and community laws are kind of changing now in terms of basically anyone with the Omicron infection can spread the virus to others regardless of vaccination status. So that's been a change in the last certainly 6 months in terms of how laws are and things like that. Throughout the pandemic, vaccines have been effective at preventing against at least some severe illness, hospitalizations, and deaths, which I think is the main benefit of vaccines, is that it's not going to necessarily it's not even going to necessarily reduce your chance of getting an infection, but it can often reduce the chance of getting a severe infection, which is described basically as needing to get hospitalized or dying from an infection. So that is considered benefit of most vaccines, that are approved by the FDA and recommended by the CDC. So CDC does again recommend a full vaccination for everyone aged 6 months and up. Now, if someone got infected based on, if someone had Omicron, let's say recently, and they're like, when should I get a booster? It's recommended based on general vaccine principles and immune system principles that you could wait for 90 days after an infection before getting a vaccine or booster. So let's talk about some critical thinking about the boosters now, Q&A, and this is kind of where we can talk about questions and answers and stuff. So we know that the bivalent vaccine is, again, 50% from the original virus and 50% from the BA4 and 5. It's not really clear why they still have the original in there, but I think the idea is they're trying to hedge their bets in case there's some sequences that match the original later. That's my thought about it. But that's why it's called bivalent. Will the booster antibody response in mice that was seen in that clinical trial, or rather in that basic science trial, be seen in the clinical trials, meaning in human trials? So we don't know if it will. The data is expected in 2 months, and human trials are ongoing. We know that the new boosters, we don't know actually if they're effective at blocking infections. Meaning it may ideally reduce the severity of the disease, but we can't really say, based on the lack of studies so far, that it's effective at blocking BA4-5 infections. And I already commented on the BA1 study, basically that the non-primary endpoints of clinical infections were not significantly different between the BA1 updated variant vaccine and the original vaccine. Now, the other justification of approval is that the FDA emergency use authorization approval mirrors the process used every year for the flu shot. So human clinical trials are not performed for each new flu vaccine every year. And I think the FDA is it seems that they're treating it this way for the COVID shot. That's just the justification from that. Here's some more sort of critical thinking, just to kind of open up discussion here is, how does the duration of immune response influence how we think about COVID? How long, if someone gets COVID, someone gets Omicron, especially now since it's Omicron, how durable is that immune response? T cells may last a long time, which may prevent against severe infection. Maybe not for everyone, but for most people. B cell response, meaning antibody response, is more variable, and it often goes away even within 3 months for a lot of people, but it can last for longer in different people, and it's hard to predict, what that duration is per each to make it a general recommendation. There's also a risk factor in terms of, should you get a booster or not based on health issues. So certain risk factors like advanced age or a body mass index, cardiovascular risk factors, et cetera, may raise your risk and push you more into the higher risk camp of of that. There's also, I think, public health considerations, things like, if we have more people vaccinated, or if there's less infections overall, does that mean that the virus won't mutate as much? The other question is, does that mean that if there's a decrease in viral load, a decrease in severity, there's going to be less transmission and we can move on from COVID, a little bit easier, or at least, make it more of an endemic situation and not as deadly for people. So that's a public health consideration. And then the other thing is, which we kind of touched on already, but if someone already got COVID, should they get the updated booster? So I'd love to hear thoughts about that. I think in some ways, we just heard the CDC recs, for everyone to get a booster. I think, it can be more nuanced than that as well, in terms of individual choice, based on some of these issues here that were presented. Okay, might go to some questions now. Thank you for the questions. What do you think about repeat infections and the increased neurological impacts that researchers are beginning to cover? I think it's like, thank you, Deborah, for the question. I think it's like the immune system, when it takes a hit and there's repeated infection, there's different molecules that get activated, like C-reactive protein and what is called NF-kappa beta and things like that. And so it's in a way, depending on the severity of infection, it could be like a boxer. If it's like a boxer gets punched a lot, maybe the first punch is okay, but maybe the fourth or fifth punch is not good for them. We know that viruses in general, and I'm talking about not just COVID, but even other viruses, can decrease what's called mitochondrial biogenesis and mitochondrial function. So that's just basically saying that your brain can take a hit from that. There's decreased mitochondria, meaning some of the batteries inside the cells that make the energy to have your brain and body function. So, if you could avoid COVID, yes, I think that would be good. If you can reduce the chance of severe COVID, that probably is going to be more protective, for you. Hard to completely say, but yeah, I think you can also do some things to mitigate that your immune system response to infection by, for instance, downregulating the inflammatory cytokine cascade, decreasing overinflammation. So having a balanced response to a COVID infection versus an overactive response may end up protecting your brain more if someone gets repeat infections. I hope that answers the question a little bit. Okay, thank you. Megan asks, what is your opinion about the risk of a severe POTS flare or a risk of experiencing long COVID in someone with POTS who gets the virus? I think this is similar to Deborah's question, if there's going to be more inflammation and more tipping of the scale, so to speak, in the setting of POTS, which we, from a functional perspective, kind of think about it as an autoimmune condition. So it might be tipping the immune system a little bit more out of balance. And I think there could, I don't know that there's going to be research on this. Okay, I think in the future, I don't know if there's a lot of research on it early on like this, but certainly, certainly seeing clinically that we do see that, so I think that certainly is possible there. Okay, so if no antibodies, how will my immune system work against COVID? What produce antibodies if exposed? Yes, thank you for that question. So what happens is if your system gets exposed to COVID and virus kind of gets in there, then yes, what will happen is your body will produce antibodies eventually, towards the virus. I think having had prior infection or vaccination, in theory, what that does is it primes your body that already has some antibodies. So it's already kind of right. It's like if I was on this webinar, let's say, if this webinar was an antibody or something like that, right? And I didn't know what we were talking about, but we were talking about, red cars or something, and instead of COVID. Sorry for the tangent, but that's kind of, I wouldn't be prepared for it. But because I know we were talking about COVID, I'm researching this and, presenting this and stuff. So I think in a way, like I said, infections and vaccinations are kind of a primer, but yes, your body has an amazing amount of, millions of cells of, over 100 million cells of white cells and basically immune cells. And you're gonna produce antibodies. It's just not gonna be as quick necessarily as if you got primed for it. Okay, thank you for that question, Joan. So Linda's asking about, can people who have gotten 3 doses of the mRNA vaccines, which is like the Pfizer and Moderna, get the Novavax vaccine as a booster? So I think technically no, meaning it's not, Novavax is not approved as a booster. The only thing that's approved as a booster is the updated bivalent mRNA vaccines. And actually the bivalent vaccines have replaced the original vaccine as the booster now. So pretty much they're saying get the bivalent booster, whether you've gotten Pfizer or Moderna or Novavax, then the end game is get the booster from Pfizer or Moderna, no matter which one you got from the primary series. You know, could it work? I think there's no evidence, there's no data, but there's biologic plausibility, but it's not part of the guidelines. So that's really all I can say about that. Thanks for the question, though. Right. Does the evaluation of safety look at VAERS data? I think the VAERS data is kind of like what's called post-marketing surveillance, is my understanding. So it looks at, you know, safety data in clinical phase 2 and 3 trials. Is going to be, you know, usually just looking at internally, usually from the drug companies often. So VAERS data is by definition often, you know, afterwards. But yes, I think that should be part of the evaluation of safety from a holistic perspective after but that is typically after something gets released and approved, and a lot of people will start using it and they report it to VAERS. Okay. Laura said, we are still being very careful, masked inside everywhere but the home. People are seeing okay, so it looks like your spouse is your spouse's doctor saying there's a spike and have had arrhythmias after a COVID infection. Yes. Yes, I think clinically people are seeing that, right? There's a spike in new patients with arrhythmias, yeah, secondary to a recent COVID infection. Hard to know why that is, but we know that there's also some risk of myocarditis, which is an inflammation of the heart muscle. So my general thought about it is there's some heart muscle or electrical rhythm imbalance that is precipitated by COVID infection. Okay. Thank you for that. I've also had all the previous Pfizer vaccines. I'm thinking about taking the latest vaccine. So based on the guidelines, you would be eligible for the, you know, for the updated vaccine. If you want to ask more specific questions about that, let me know. But yes, that would be an updated guideline per the CDC. Okay, Eva showed. So I'll probably stop right there. We'll answer more questions in a bit. So we'll go into the other pieces in a minute. Yeah, let me just get through a couple other slides. And maybe Jen, you can tell me on the time, where are we on the time? So what is next for, sorry? It's
12:35.
Oh, thank you. Great. Okay. So what's next with SARS-CoV-2? So one of the challenges we have, I think, as a world society is that there's declining surveillance and testing. So that may impact how we estimate what's ahead. In fact, I think I have it in one of these slides, but there's some estimates of basically gross underestimation of infections, you know, because people are not testing as much or not reporting it to the CDC as much, essentially. So that may impact some of the data analysis. The data is not going to be as accurate, essentially. So currently, though, it's estimated that about 83% of infections in the US are the BA.5, which is the Omicron 5 variant. There's a few others that are a little bit more minor, but BA.5 is considered still the dominant one. And it's expected, unless there's something surprising that happens, that future surges, you know, the next one probably would be in mid-December, January, which would still be BA.5. You know, it would still be likely the dominant one now. They do note, just to hedge their bets, that the variant scene can change quickly. There's also questions about, you know, should you get the flu shot and the COVID shot at the same time? I think for most people, it's probably fine to do that. That is the official recommendation from the CDC, is you can get them both at the same time. If there's an individual concern about that, you know, certainly can put in the chat or, you know, talk to one of us if you're a patient here at CIH. But there is also, just so you can kind of try to time your flu shot, there's a weekly page that the CDC puts out in terms of where the flu cases are and how much and stuff. So that link is right there for you. We're going to get into treatments because someone asked about EvoShield, so I thought it'd be good to talk about this. So if you're looking for different therapeutics like Paxlovid or monoclonal antibodies, there's a Department of Health and Human Services therapeutics locator, which is this link right here that you can go to. And if you go there, you can pretty much look up any treatment for COVID-19 and then where you can get it from. So that's kind of nice. So let's talk about Paxlovid. So we all know this is a drug produced by Pfizer. It's an oral pill. It's a 5-day course that's indicated by the FDA for people with mild to moderate COVID-19 who are at high risk for progression to severe COVID-19. So there is some room for interpretation of what that means. But Harvard researchers have actually found that up to 27% of patients have symptom rebound after initial improvement, meaning they get COVID, they have symptoms, they take Paxlovid, they feel better, but then up to 27% of people start having symptoms again. And up to 12% of people have viral rebound after initial improvement, meaning their test turns positive again, like the rapid test. So that's from Dr. Lee and researchers at Brigham and Women's Hospital in Boston area. So, we know this is a significant amount. We've certainly seen this in our practice. So we think about, this is that it can work for some people. And when it works, it's probably that it just gets it in time where all viral replication stops and the patient feels better. They don't retest positive. They don't retest positive in terms of symptoms as well. Now, when it doesn't work, there's what's called a Paxlovid rebound, which is that there's not enough of the drug that got to the infected cells to stop the viral replication. Probably the virus is hiding inside the cells and then reemerges later once the Paxlovid isn't being given. And there could be many reasons for that. It could be that the duration needs to be longer. In terms of instead of 5 days, maybe it needs to be 10 days. There might be some what are called genetic variations in drug metabolism, where some people might metabolize a drug faster or slower, and that might impact the effectiveness of Paxlovid. And then there might be, from a functional medicine perspective, more of an absorption issue. There might be something with people who have gut health issues or cell membrane health issues that affect the absorption of that medication. In terms of, so I think it is a bit individual there. We do use this sometimes to try to reduce viral replication and severity if someone has symptoms. Sometimes people do get rebounds, so it's something to know about. Monoclonal antibodies updates. So basically, there were some other previous generation monoclonal antibodies that have been phased out based on the resistance of BA.5 to those antibodies. Now currently we have what are called EvoShield, which is given intramuscularly, and then we have something called bebtelovimab, which is an IV, also given in these different infusion centers. And you can look that up on that therapeutics locator site and see where that's available in the DMV area if you're local here. But they are available for people that are at higher risk of progression to severe disease as well. So we're going to touch on nutraceuticals, natural supplements. Are they effective in COVID-19 and post-COVID prevention and treatment? There's a nice research paper I found that was published very recently that kind of goes through different evidence for different vitamins and minerals. Most of them are association studies and biologic plausibility studies. There are no specific randomized controlled trials on vitamin supplements. There are some clinical trials underway for post-COVID syndrome, which is good. And clinical trials in general are needed on these vitamin supplements for basically boosting the immune system. We can't really say that we're going to prevent or treat with supplements. That's just not something that we say legally, but we can say that, is there a way to boost the immune system and, improve wellness, So the principal nutraceuticals that are being studied in these trials are the following: vitamin C, vitamin D, vitamin E. You can ask us questions here on the chat if you have a question about a specific one. Flavonoids, which are found in things like fruits, vegetables, and other kind of whole foods. Prebiotics, probiotics, zinc, and melatonin. So those are the principal nutraceuticals that are being studied. Now, we could say, in the absence of these like randomized controlled trials, we could approach from a functional medicine perspective and a lifestyle perspective, we could approach this as food as medicine. There's certain foods that have been shown in basic science studies, for instance, to lock down the ACE2 receptor or to make the spike protein, not being able to get into the cell as easily and stuff like that, which we presented on previous COVID webinars, looking at nutraceuticals, having a personalized health approach with things like the biologic plausibility, things like a history of physical lab testing, to make more informed choices about individual treatment approaches, so it's a more personalized approach. So that's what I would say about nutraceuticals. Let me see, we can probably go to more. So yeah, so I think you can use EvaShield as pre-exposure prophylaxis for a high-risk population. Deborah, I think the benefits would outweigh the risk there. Okay, timing of the booster for someone who's had a recent infection. Yeah, so that would be about 3 months. You would wait about 3 months, basically. Didn't previous vaccines prevent infection? It probably wouldn't. I mean, it could reduce the chance of severe infection based on that T cell pathway that I was mentioning before. Yeah, and then back to another question, Ruby, you had 2 initial vaccines and 2 boosters. So again, it would be just, you would still need, based on the guidelines, to get the updated version, since everything is more BA.5 now, essentially. Yeah, I think the COVID booster, the recommendation is after any, after a COVID infection, not after any viral infection, because those viral infections are not COVID. Myocarditis, there are some studies showing that there is a risk of myocarditis, typically in males, like younger males. I think this is seen for both vaccines and infections, really. Most people do respond and recover, but there's not any long-term studies yet because the pandemic is still too new, but I imagine there will be studies in the future about this. Bivalent booster and pregnancy, I don't know that there's data on that, honestly. I don't think, I think we just have to extrapolate back to the previous vaccines, and you know, it's sort of recommended that it's fine, and pregnancy was my understanding in terms of the other vaccines, COVID vaccines. But in terms of bivalent, I don't think there's anything specific studied on pregnant women. Okay, should a person who has had myocarditis, these are great questions, have another booster? That's a risk-benefit analysis there. Honestly, that it's hard to have a blanket statement on that. I mean, certainly some people, there may be that the risk outweigh the benefits there, you know, for that. Okay, I don't know what glass jaw theory is, but it sounds really cool, so thank you. Would red light therapy be good for COVID? So it could be helpful. Thanks, Mustafa, for the question. Would it be good for, do you mean like treatment? I don't think we could say it's like a treatment for COVID. You know, I think we can say that in theory, if someone's trying to recover from long COVID or increase, you know, their energy, then red light therapy has been shown to boost the mitochondria through the near infrared spectrum, activating the mitochondria at a distance of 4 to 6 inches. So that we know. But in terms of prevention or treatment, I don't think we can say that really. Okay, thank you. Are studies showing getting repeated infections of COVID increasing the chances of developing long COVID? I think it depends, Alicia, on the viral load a little bit more, of how severe each infection is. I wouldn't say that's where I've seen, you know, most people get that, but I think I don't think the data is out there yet on repeated infections and developing long COVID. In theory, it would make sense that if people get it, you know, too much, and too much might be individual for each person, you know, in terms of what that too much is for each person might be a little different based on their health conditions, genetics, and stuff like that. So yes, I think there would be a potential risk for that, just based on the repeated exposure. I think, again, the main thing is to keep the immune system in balance. You know, if there's imbalances in the system with, you know, things, and we're talking about more general functional medicine now, but, you know, gut health or immune health, keeping what's called the Th1, Th2 axis in balance, then I think this, you know, increasing different immune supportive nutrients that help keep that immune system balanced, things like vitamin A, vitamin D, zinc, omega-3s, probiotics, stress relief, you know, all of that. So thank you for that question. The current FLCCC guidelines. So that is a protocol by some critical care doctors that uses various treatments that can be potentially helpful. I think some of the studies and some of the clinical results that people have seen have shown benefits from the FLCCC guidelines. I don't really have too much more of a comment on that unless you have a specific question about that. Yeah, so Jonathan, I think for the effects of the BA.4/5, they seem to be similar to the effects of the other mRNA vaccines based on the safety studies. There didn't seem to be any like specific extra or different side effect risk from the mRNA, from the original vaccines, I should say. So sometimes people might have to use their own body as a guide. Like if you reacted okay to this one, in theory, again, I mean, it's not predictable, but you could react similarly to the next one. I mean, yeah. So that's Megan's answer too, I think, for that one. Okay, so if you got the bivalent but not the flu shot yet, well, according to the CDC, you can get them both together. From a more functional end, if you're trying to just kind of let the system calm down, I'd wait 2 weeks. How often have you seen COVID rebound without Paxlovid? Yes, it does happen. It definitely still does happen, Stephanie. Yeah. So yeah, that definitely is possible. And I think it's a similar mechanism, really, is that there's just a persistent virus in there, a lot of times, and then, just your immune system just trying to deal with it, basically. Okay, Carol's asking, if one has gotten the original vaccine and 2 boosters, how long should the benefits of severity of illness last from the vaccination 2 boosters? Good question. In theory, it sort of depends on the antibody levels a bit, but remember that those antibodies are more specific. Well, they're specific against usually the spike protein, and there is some, resistance to neutralizing antibodies from BA.5. So I think there is some caveat to, how, do we know exactly how much protection there is against severe illness if someone had a vaccination and 2 boosters? I don't think we really know that, completely. So I think the official rec is to get the updated booster, after 2 months, basically. Okay, that's good. You were saying, Deborah, so someone with myocarditis, young males, kind of dial down activity, moderate activity, reduce exertion for 4 to 6 weeks and things like that, so kind of some rest. Bivalent vaccine, I think this is available at a lot of pharmacies now. You can probably go to therapeutics locator or just call your local pharmacy. They should have some more information about that. It's in a lot of places now. Long COVID risk, that there might be some questions about this. Omicron does seem to have less of a chance of having long COVID versus Delta based on a Lancet study. You can see about 1/4 to 1/2 of that risk versus Delta. But, it is known that, Omicron could cause long COVID, so it's not like a 0 risk. And estimates of the prevalence in the US, CDC data from June are estimating about 1 in 13 people, about 7.5% of US adults have long COVID symptoms, which are defined as new symptoms that someone didn't have before COVID, that are lasting for at least 3 months after first contracting the virus. Let me see what I wanted to say about this. This was a study done from City University of New York. This is specifically measuring BA.5, which is the current variant, and then sort of like how many people had long COVID, which they were defining as a 4-week interval. So they were saying that, at least 4 weeks after getting COVID, over 20% still had symptoms. So that's not an insignificant amount there. There's still a lot of people that were reported. The other thing that I think I wanted to point out here is that, during that 2-week study period where researchers in New York called different people across the country, 17% of people in that 2 weeks, 17% of the people had the infection, which is 44 million cases if you extrapolate that out to the entire US population, versus only 1.8 million reported to the CDC during that period. So, up to 20 times as many people were getting it as reporting it. So that's kind of an interesting thing. A lot of people were getting COVID during the summer. Root cause of long COVID. I think more and more that microclots, which is the third point here, is a big factor in terms of reduced circulatory response, microcirculation issues, low nitric oxide. There's also ongoing inflammation, persistent viral infection, autoantibodies, and then what's called mitochondrial dysfunction, where people just feel fatigued because there's a battery drain via decreased ATP production, decreased energy production by the body cells. So here's some general thoughts on long COVID protocols. Lifestyle is important, integrative treatments are important, an anti-inflammatory diet, things to support nitric oxide, things like greens and beets and exercise and sauna if you have that. Investigate hypercoagulability. You can do it through blood testing, looking at is there a chance or an increased risk of microclotting, especially if someone has long COVID fatigue and long COVID symptoms. Consider some things to help break up those what are called fibrin biofilms that might be driving some of that hypercoagulability and support nitric oxide, which is the most previous bullet point. You can also promote what's called ACE2 activity with angiotensin converting enzyme 2 activity, which is going to help dilate and keep the arteries open, which is kind of what you want in long COVID, with vitamin D3 and also with glutathione as kind of a synergistic effect with D3 and also resveratrol. Melatonin to reestablish circadian rhythms, which you can do either naturally or through supplements. General mitochondrial support that you see there, IV nutrient support if needed, and then low-dose naltrexone is a compounded medicine that can help reduce some of the brain cell and immune cell inflammation that you see with long COVID. You talk to your functional practitioners about that. Just in summary, we're all connected. Just take home points that really COVID-19 is becoming an endemic virus. We need to strengthen our collective immune system and general health. Updated booster shots are now available, and research on vaccine efficacy and treatments continue to be ongoing. And of course, I usually say this during these webinars, but we need to look at both personalized medicine and community health and work together for the best outcomes for all of us. So I think wanted to just thank you all for coming in today. I have a special announcement. We have a few minutes of this. Should I get to more questions? Maybe we'll get to a couple more questions first. Let's see. Bivalent vaccines also at some Montgomery County health clinics and high schools on weekends. Thank you, Kathleen. Is there any scale to interpret the clinical implications of the T-detect test? I'm not sure about that. That's if it's something that you want to do and we can, research it, definitely let us know. Oh, great point, Stephanie. There is something called the Annie Hopper DNRS training, which is also called Dynamic Neural Retraining System, which you can find at retrainingthebrain.com. Has resolved long COVID for many people. So thank you for that comment. So you can basically train your brain in neural pathways to help overcome long COVID. Thank you, Deborah. Thank you, Mustafa. Thanks to everyone for coming on today. So special announcement. So we have been here for about 8 years. We've been so grateful for all your support and just coming together as a community, especially in the difficult time of COVID. In our first location here in Bethesda. So drum roll. So we are actually going to be adding a second location, which will be in Potomac, Maryland, which is about 10-15 minutes up the road in the Cabin John Village Shopping Center, which is going to be opening in early 2023. So we'll be keeping our Bethesda location. So please don't worry, we're going to be here as well. And we'll be opening up in that shopping center in early 2023. We will provide more details than we have in terms of the exact timing. But I did want to thank one patient actually that suggested to us to go and to look at the Potomac. So I just wanted to thank her for that too. So thank you. You know who you are. And yes, we certainly would be open to looking at different places, but certainly we are very excited for this location and hope to continue to be of service to the community. So thank you for all the support and thank you for listening today. If anyone has any questions more, we can do that. Otherwise, wish you all a safe autumn here and fall and good health for you and your loved ones. Thank you so much. Great to see everyone here. It's been a while on our webinars here. So since we have a minute or so, I'm curious if, since a lot of people here I see from like previous webinars and everyone, if we had webinars, brought back some in the future for the webinars. I know we have our podcast now we're doing every week, which is really great. What kind of webinars would you want to see if we did, some webinars, these live webinars more in the future? How frequently would you think about having them and things like that? I mean, we have our ideas, but we kind of want to hear that from you as well, if you have any opinion on that. Toxins, okay, good, definitely good thing to talk about. Live webinars, yes. How frequently do you think there would be? Okay, once a month. Yeah, that's something to definitely work towards. I think we're continuing to have that capability. All right, a lot of people saying once a month. Okay, that's nice. That's nice. Yeah, it's great to see everyone. I do see a lot of people from 1 year ago, 2 years ago. Great to see everyone here. Yeah, so thank you so much. Healing the nervous system, that's a great topic. Yeah, and we are very grateful for you as well. So we will be seeing you again very soon. If you haven't checked out already, Jen's putting together a great podcast. You can look at that on Capital Integrative Health CIH podcast, basically. Yeah, but definitely we are planning, more webinars in the future, so look forward to seeing you all there too. All right, well, thank you so much, and have a great rest of your afternoon.